Good morning. I'm John Bitson, the Menard Family Director of the Sheila and Robert Challey Institute for Global Innovation and Growth. Welcome to the Human Progress and Flourishing Workshop. In this workshop, we bring in speakers from across the country to present insights from their research and experience with the NDSU community. Topics focus on innovation, opportunity, and ways to increase individual and societal flourishing. I'm really excited that we have Dr. Phillip Phan here this morning to talk about the importance of an honest debate during a public health crisis. And we're going to have he's going to give a short presentation and leave a lot of room for discussion. And so I hope we have a great discussion and conversation this morning. Phillip H. Phan is Alonzo and Virginia Decker Professor at Johns Hopkins Carey Business School, with joint appointments as professor in the Department of Medicine. He is Robert Bosch Policy Fellow at the American Academy in Berlin. His academic and professional work focuses on innovations in healthcare that impacts patient safety and quality. He has published more than 200 peer-reviewed research papers and is author or editor of 13 scholarly books. He is deputy editor of the International Journal for Quality in Healthcare, academic editor of medicine, and associate editor of the Journal of Technology Transfer. He reviews for the National Academies of Sciences, Engineering and Medicine, National Institutes of Health, and the National Science Foundation. And he has a much longer resume. He asked me to shorten his bio this morning. So super excited about the discussion and conversation we're going to have this morning. Let's all welcome Dr. Phillip Phan.
Thank you. Thank you, John. So I've also been asked to repeat the question. So I'll have some prepared remarks, and then we will go into question, and actually more of a discussion rather than just question, because it's really a conversation that I like to have with everyone. So I would first of all like to thank Dr. John Bitson, Director of the Challey Institute for Global Innovation and Growth, for this kind invitation to this discussion. I think it's a very, very interesting program. I would also like to thank Alison Fulton and Tate Reinhardt and their team in facilitating my attendance today. So shout out to the team. I'm going to reflect on some lessons learned, and there are many, from the COVID-19 pandemic, and what we need to do in future responses. This talk is the product of a panel that I moderated at the Johns Hopkins University last year. That panel included Drs. Scott Atlas, Jay Bhattacharya, Marty McCurry, and Joe Marine, the latter of whom is the Chief of Cardiology at Johns Hopkins Physicians. I want to note that all opinions in this presentation and any mistakes are mine and mine alone. You should not attribute them to Johns Hopkins Carey Business School, Johns Hopkins Medicine, or Johns Hopkins University or its affiliates. Freedom of speech is foundational to scientific progress. Yet during the COVID-19 pandemic, public health policies such as lockdowns, school closures, and mask and vaccine mandates were imposed without sufficient consideration of emerging evidence, overall welfare impact, and even long-standing knowledge of the science of physiobiology. Physician judgment was frequently subordinated to government dictates with significant ethical, legal, and societal impacts. The pandemic underscored the tensions between the top-down messaging and the unique responsibility of doctors to use their best professional judgment to engage in free dialogue with their patients. The tension between public health directives and physician autonomy is unnecessary and counterproductive, I will argue. Instead, public health guidance should support, not override, clinical decision-making. And similarly, physicians themselves should consult with and be guided rather than dictate to their patients. These same arguments should apply, by the way, to any credentialed professional that claims the trust of his or her client and has the ethical obligation to act in the best interests of the latter. So I would include their accountants, lawyers, engineers, right? People who claim expertise based on their training or their authority. Now we know one example, you may be less familiar with the other example. In the early 17th century, Galileo Galilei, an Italian astronomer, physicist, and polymath, publicly supported the heliocentric model of the solar system, which originated from Nicholas Copernicus, which proposed that the Earth revolved around the sun. This model directly challenged the long-standing geocentric view endorsed by the Catholic Church, which held that the Earth was at the center of the universe. Using his telescope, Galileo gathered observational evidence such as the phases of Venus and the moons orbiting Jupiter that strongly supported heliocentrism. However, in 1633, Galileo was tried by the Inquisition, found, quote, vehemently suspect of heresy, and forced to recant his support for heliocentrism. He spent the rest of his life under house arrest. So Galileo's condemnation highlights the tension between emerging scientific discoveries and the established beliefs, and could as easily apply today, as we shall see. In the mid-19th century, British surgeon Joseph Lister proposed the revolutionary idea of using antiseptic techniques during surgical procedures to prevent infections. Influenced by Louis Pasteur's work on germ theory, Lister proposed that microorganisms were responsible for the high rates of post-surgical infections and mortality. He advocated for the use of carbolic acid, otherwise known as soap, to sterilize surgical instruments, clean wounds, and sanitize operating environments. The concept of the sterile field in surgery originated from Lister's work. However, his ideas met with considerable resistance from many in the medical community. At the time, the prevailing belief was that infections are caused by bad air or humus, and was simply an unavoidable part of surgery. Many surgeons were skeptical of germ theory, resistant to changing long-standing practices, or simply unwilling to adopt the rigorous new protocols that Lister recommended. Physician autonomy refers to the ability of doctors to make independent clinical decisions and express their opinions based on their knowledge, training, expertise, and experience in clinical care. This autonomy is essential in ensuring that physicians can provide patient-centered care tailored to the needs of the individual. We take that for granted, don't we? Autonomy to exercise independent judgment is foundational to effective patient care. A classic example is the prescription of drugs approved by the FDA for clinical indications other than that for which the drugs were approved. We call these off-label prescriptions. Off-label prescriptions make up more than half of prescriptions that are written by doctors in the United States. The basis for physicians' autonomy comes from the elevated status in society that began with modern medical education, the modern medical education curriculum. In the 19th century, medical education was ad hoc, unorganized, and of varying quality. This changed with the Flexner Report of 1910. Abraham Flexner, at the time a very well-noted American educator, was commissioned by the Carnegie Foundation to evaluate the quality of medical education in North America. The report concluded that most medical schools were poorly equipped, lacked rigorous standards, and offered inconsistent training. The sweeping reforms included higher admission standards and emphasized scientific research and evidence, integration of medical schools with universities, and a focus on laboratory and clinical training. This dramatically reshaped American medicine and led to the closure of substandard schools, elevation of medicine education to graduate program status, standardized curricula with Johns Hopkins as the model, and introduced the residency as a required training for certification. Medicine became a prestigious, respected, and well-regulated profession, with physicians seen as highly educated experts with authority and public trust. Physicians hold a unique position in society as they interact with individuals during their most vulnerable moments. Physicians are also unique because they're granted almost blind trust by their patients. That trust is granted because medical care and medical science are deemed esoteric knowledge. It would be unreasonable to think non-medical or non-medically trained citizens would have the time or the means to sift through the volumes of medical science research and texts. With this trust comes a tremendous burden of responsibility. Such profound trust is based on two critical assumptions by patients. Number one, that physicians have a keen ability to use critical thinking. And two, that physicians operate with a high degree of ethics and a strong ethical compass from their training and from the commitment to patient care. Maintaining the trust of the patient requires that the physician acts in the patient's best interest and not as an agent of another, for example, as an agent of the government. During the COVID-19 pandemic, this autonomy was challenged by public health officials mandating standardized policies intended to protect the population. Public health leaders favor uniform messaging for clarity, but determining scientific truth depends on open debate. While public health guidance is helpful for managing large-scale health crises, it should not subordinate patients' clinical judgment, especially when the evidence underlying the guidance is weak or emerging, as was the case during the early days of the pandemic. A good example is the 6-foot physical distancing mandate. You remember that? They were marking pathways and lines with these 6-foot marks that people had to stand on, elevators and things like that. As far as we can tell, there's no real-world evidence for this policy, but it led to costly investments by businesses and communities to comply. We must remember that the ultimate victims of a public health crisis are not a population, they're human beings. In a free society, public health guidelines should recognize the primacy of the physician and patient autonomy in decision-making. When conflict arises between guidance and individual freedoms, it usually suggests a problem with the guidance. During the COVID-19 pandemic, rigid messaging often clashed with scientific discourse. Physicians were sometimes forced to choose between adhering to governmental mandates or providing individualized care for their patients. This dilemma was exacerbated by the blanket requirements of lockdowns, business closures, masking, school closures, and vaccine mandates, all harboring potential and known harms while disregarding well-known data on viral respiratory infections and established understanding of lockdowns and their effects. Lockdowns would, in the last in the COVID-19 pandemic, the use of lockdowns was not unique. Lockdowns have been used before, and we actually have evidence of what happened during those periods. Vaccine mandates, for example, were justified to protect the patient's loved ones. Remember that? Get the shot or kill grandma? This is a novel justification for vaccination, which has always been about protecting the individual, not others. For freedom to be truly guaranteed, it must persist regardless of any well-intentioned public health policy. So I begin from the point that these policies were well-intentioned. They were designed to presumably protect public health. So some of you may have seen this before, but let me describe it very briefly, right? These are the crude mortality rates. So this research was done around June of 2020, and it already showed very strong emerging evidence that the virus was quite fatal to individuals that were 80 years old and above who contracted it, and basically had very little impact on individuals that were below 29 years of age. In fact, the crude mortality rate of people who were younger than 29 was much less than the flu. The Great Barrington Declaration, co-authored by Martin Kulldorff, professor at Harvard, Sunatra Gupta, professor at Oxford, and Jade Bhattacharya, professor at Stanford, anticipated this finding because it was actually based on evidence that had come out around that time. These were based on early studies in the spring of 2020 by Dr. Bhattacharya's team in the San Francisco Bay Area. And he basically found that the actual serum positivity of the virus in a random population was 5 times that of the symptoms that were actually reported that were attributed to the virus. So the thing had already spread. right, with relatively few widespread effects, especially among the young. The Great Barrington Declaration called for focused protection on older adults while allowing younger adults to get on with their lives. The reaction was a now very famous text message by then NIH Director Francis Collins to NIAID, the National Institute on Allergy and Infectious Diseases Director Anthony Fauci, for a, quote, devastating takedown of the authors for daring to contravene the public health consensus. In fact, there was no such consensus, as evidenced by the 1 million signatures of experts that co-signed the declaration. We must recognize that public health guidance is just that, it's guidance. Guidance should be written and conveyed in a way that acknowledges the possibility of correction in the face of new evidence and the need for flexibility and adaptation in different clinical settings and social economic contexts. We already know this because this is the case with established clinical practice guidelines. So much of medicine, especially in well-established domains, follow clinical practice guidelines. So CPGs are developed with the best evidence, strong interrogation from literature, and a great deal of consultation with subject matter experts. And yet, with every CPG that is issued by the professional societies, there are always caveats in their recommendation. Doctors are ultimately responsible for either following the guidance or not, depending on the particular circumstances that their patients face. So within that framework, the CPG framework or the public health guidance framework, we must never forget the informed consent of the individual patient, not pressure or blanket mandates, is the gold standard for all ethical practice. So we understand the concept of informed consent. You have to give informed consent to be treated when you visit a hospital. You have to give informed consent when you participate in a research study. Right? Informed consent is the basis on which the ethical relationship between the doctor and the patient is grounded. And so that gold standard, right, should never be violated, even in a public health crisis. Now, it's not surprising then that trust in institutions like the Centers for Disease Control and Prevention and the Food and Drug Administration declined sharply, and trust in physicians and hospitals dropped from 72% in 2019 to 40% in 2024, according to a survey by Perlis et al. Published in JAMA Network Open. This erosion of trust stems partly from physicians failing to question public health guidance that lacked strong scientific evidence and sometimes even defied common sense. So in a way, we're sort of putting the blame on physicians, right, for not having a spine, so to speak. Patients depend on doctors for critical thinking and knowledge of the data, yet many physicians merely echo recommendations without fully understanding the evidence. Worse, some pressure patients into adherence rather than persuading the facts. The right to free speech is a cornerstone of democratic societies. Free speech within the medical profession takes on an added significance due to the potential impact on health outcomes and the unique level of reliance on doctors by patients. During the pandemic, many physicians who raised concerns about public health measures, such as mask mandates for young children or vaccine policies for teenagers, found themselves at odds with both governmental authorities and social media platforms, which labeled dissenting views as, quote-unquote, misinformation. Physicians were censored for expressing views that contradicted government health policies, even when their views were backed by scientific evidence and basic biology. This censorship was justified on the basis that there was already a consensus. Here's the problem. You can get a consensus if you ask enough people, regardless of their incentives or motives to agree. However, we know this: consensus does not mean that a truth has been found. Recall Galileo and Lister? For example, discussions on natural immunity after recovery from infection were suppressed or labeled as misinformation by social media platforms, sometimes under pressure from government agencies. In a free society, making the case to the public rests on demonstrating compelling evidence. It means that you have to respect the intelligence of the people. You have to respect the intelligence of the electorate. Data-driven arguments should guide discussions and the ability to craft effective public health responses. This starts with the ability to freely debate and question government mandates, especially when scientific evidence is still emerging during the early days of a crisis. Suppression of dissenting views can lead to harmful policies being implemented without adequate scrutiny. Once implemented, such policies actually are very difficult to reverse because public health leaders have staked their professional reputations on these very public decisions and pronouncements that they've made. And because, more importantly, once false premises are widely accepted, the false conclusions that these premises lead to can linger for years. Although censorship was done by social media companies themselves in 2020, when lockdowns and school closures were being imposed, litigation such as Missouri versus Biden exposed the role of the federal government in pressuring social media companies to censor discussions related to COVID-19 policies. Many physicians and medical scientists were censored even by their own institutions for questioning prevailing narratives, something that fostered public confusion and fear rather than trust and compliance. Although many physicians were interested in engaging in public debates and ensuring health policies account for real-world medical risks, speaking out could and often did bring professional and personal risks. I mean, we know of nurses and doctors that were fired because they expressed a dissenting view or because they simply refused to accept the vaccine mandate. So that's just a known fact. While acknowledging that doctors have an ethical responsibility to their patients and that they're vital in shaping public health conversation, we also have to understand that they're not inherently public policy experts. Clinical medicine, virology, and epidemiology are just parts of a complex system that include economic, legal, and behavioral considerations. Titles do not equate to sound policy expertise, as many well-credentialed experts were proven wrong. Only collective wisdom grounded in free speech will produce the best health policy expertise. Now let's look at some of the consequences when public debate and open debate is suppressed. We know that the lack of open debate on school closures led to severe educational setbacks for children, and I'll show you some data on this. This is not my data, this is data from other studies that are widely reported. And suppressed discourse prevents necessary course corrections in public health strategies. So, we saw early evidence of mental health impacts, especially on young people, and these were simply ignored, or they were chalked up as, well, the cost of saving the world. So in a report by the Annie Casey Foundation that was done to look at learning losses due to the school closures, and some states like Michigan, for example, closed schools for 3 years, right? 26% of 8th graders were proficient in math versus 33% before the pandemic. Now, 33% is already a failing grade, right? So these were school kids that were not able to do math at grade level, and it actually got worse because they stopped going to school, or they had to be homeschooled, and parents who were sending kids to school were not prepared to homeschool their kids. 32% of 4th graders only were able to read proficiently versus 34% in just the year before. And so on and so forth, right? 40% experienced at least one adverse childhood event during 2020. So an adverse childhood event is family economic hardship, parents divorcing, separated, or even going to jail. It turns out that something like $31 trillion of future US economic activity was put at risk due to learning delayed by pandemic lockdowns. Research indicates that students who don't advance beyond lower levels of math may have a 50% chance of not being employed after high school. That's a very severe economic consequence. One analysis calculates that the drop in math scores between 2019 and 2022 will reduce lifetime earnings by 1.6% for 48 million pandemic-era students. That translates to close to $1 trillion in future earnings. So the consequences are clearly economic, The problem is that it's very hard to detect it during the time that these mandates were imposed, right? It's very hard to contemplate. It's only after the fact, when you look at what the learning losses are and you look at the empirical evidence, you realize that these consequences were great. Now, here's the other interesting thing. We know that there are economic consequences for learning losses. This is from past research, so we didn't need the pandemic to tell us this. In fact, you could probably have calculated these numbers by knowing how many people were kept away from school. Okay? So this is not completely unknown, but it wasn't appreciated. So here is another graph, again, I think relatively well known if you are sort of into this. This is a chart of mental health hotline Google searches, right, during the lockdown period. So you have the lines prior to the lockdown in March, and then after the lockdown. And studies have shown that mental health impact of COVID-19 restrictions on young people were even greater than the general population trend. So this is the general population trend. The spikes are even greater if you were to take apart the data and look at people who are under 29 years of age. And here is a more serious piece of information. So this is a meta-analysis of 23 studies of individuals that were clinically diagnosed with suicide ideation. So it's not someone telling you, I mean, there are scales that measure suicide ideation, but these are individuals that were actually diagnosed in the clinic of having had suicide ideation. The dots are the odds ratios, and the red dot at the bottom basically shows that on average, right, clinically diagnosed suicide ideation went up significantly during the lockdown or as a result of the lockdowns. So again, the impact of these mandates, which, by the way, this research, I presented a bit of research yesterday of a survey that we did. That was done with colleagues from the Department of Psychiatric Medicine at Hopkins. It is well known that under great deals of stress, and especially among the generation that is 29 years and under, they face a lot of anxiety. A lot of it is economic, a lot of it is, sort of job uncertainty, that suicide ideation actually has gone up. So even without the pandemic, we know that exposure to risk and anxiety causes a great deal of mental distress, okay? The lockdowns in the pandemic basically worsened it. What are some of the lessons from the pandemic with respect to physician autonomy and health? Scientific progress relies on open discussion, and suppressing alternative perspectives can lead to flawed policies that are very difficult to reverse. We are still suffering from it, by the way, right now. If you look around, I have colleagues who still believe that vaccinating 15-year-olds is perfectly fine, and in fact it's the thing to do, when in fact there's really very little evidence of its effectiveness, and in fact there might be harms attached to it, especially for young men. The COVID-19 pandemic revealed critical flaws in the balance between physician autonomy and public health policy. Suppression of scientific debate and the marginalization of dissenting voices weaken public trust in medical institutions. The lesson from the pandemic is clear. Physician autonomy and free speech must be safeguarded regardless. Physicians must have the freedom to challenge the public health consent policies without fear of censorship or professional repercussions. Protecting these values ensures physician-centered care, patient-centered care, built on trust that doctors act in their patient's best interest. This trust relies on physicians' ability to ethically apply critical reasoning, making sure that they know the data and act with enough courage to speak even against an accepted narrative. Restoring trust in public health requires government, media, and academic institutions to promote, not suppress, scientific debate, admit error, and distinguish between known facts and uncertainty. Fostering a culture of open scientific inquiry and respect for physician autonomy starts by protecting free speech and prioritizing ethical, patient-centered care. This will ensure that our health system will be, number one, patient-focused, number two, more prepared for the next time something like this happens again. Thank you very much, and I'm happy to enter into discussion. Yes, sir.
So I remember watching a press conference with Illinois Governor Bitzer, and he was asked about how COVID deaths are reported. And he wisely introduced his Secretary of Health and stepped aside, let her answer the question. And she said, well, and I'm summarizing, is that if you have COVID and you die of any reason, then you reported as having died of COVID.
Mm-hmm.
So if you committed suicide,
Yep.
if you were in an auto accident, if your house burned down and you died, and you had COVID, then that fire didn't kill you. COVID killed you, as far as the reporting requirements. That was, and institutions went along with that because they got reimbursed based on the number of deaths of COVID. So I don't think that this was necessarily kept secret.
Mm-hmm.
I didn't see many people talk about this. I can't help but believe that physicians knew this was going on. I'm curious about why we didn't hear more from physicians about these inflated statistics.
So I was asked to repeat the question, so I'll summarize the question. The question is, what happens when a government mandate is supported by economic incentives for institutions to follow the mandate, regardless of whether they believe that the mandate was correct or not, right? And so what we found was during COVID-19, there was a lot of pressure to report mortality. And of course, the higher the mortality, the more serious the problem became and sort of justified these very serious government mandates. So the example that was given was what happened in the state of Illinois, but this was happening across the country, where reports of mortality from COVID-19 were basically attached to anyone who died for any all-cause mortality, any reason, as long as they were diagnosed with having COVID-19 at the point of death. That, of course, inflated the figures, and what the government did was it had compensation, right? So it sort of rewarded, or not rewarded, that's not the right word, but they compensated states for the services they provided for COVID-19 cases based on that kind of an accounting. So, and that's why I think it is important for doctors to speak out. And the question is, why didn't more doctors speak out? Because, as I said in the talk, they were either punished or rewarded for either going against or going with the narrative, right? So if you're working at a hospital and the hospital finances depended on being reimbursed for taking care of COVID cases, and you say, well, actually, only 20% of the deaths really could be attributed to COVID, and the rest were basically, COVID was maybe a comorbidity, maybe it was coincident to the primary cause of death. But if you did that, then you basically went against your employer. And a lot of doctors who really should have been a lot more vocal, either didn't have the incentive, but more importantly, sort of, didn't want to deal with the institutional blowback. So we saw a lot of that. So what's the cure for this? How do you deal with it? How do you, so when you have a system that has both the regulatory and the economic incentives to move public policy a certain way, and you have individuals that are trying to point out that actually this is not quite correct, how do you incentivize or how do you motivate the individuals to act according to their conscience, rather than the institutions that are pushing in a certain direction? And the same with social media companies, by the way. Anybody has any ideas on this?
Well, there needs to be protections for the physicians from the institutions that they're either employed by.
Yep.
And I assume that there's plenty of professional groups, but those protections need to be law, I'm guessing.
Absolutely. So that's the first thing. So first of all, there has to be, and the good news is that as a society, we still believe, in spite of the data on trust in physicians, we still believe that physicians, for the most part, act in the best interest of the patients, right? And as a result of that, we accord them a certain degree of not just respect, but a great deal of power. And so I think reinforcing those values is very important. And you can do that by making sure that their right to free speech is protected, and it is in fact protected. So there are, first of all, First Amendment rights. So if you say something that the federal government doesn't like, you have a constitutional right to defend yourself, number one. Number two, there are a lot of professional societies like the American Medical Association, the American College of Surgeons, that are supposedly to act in the best interest of their members, to protect them. So I think that having a conversation to figure out how we can strengthen these other institutions, to give individuals to act, more power, more freedom, more ability to act in their own best conscience, and to act for their patients, I think that's definitely a way to go. Now, that said, the AMA has also been accused of incompliance, right, with the government mandate. So the AMA, which should have stood up and said the physicians ought to have primary voice in this, did not do as well as they could have. And so in a free market, what happens? Well, you have the creation of other societies. So there's an American College of Physicians, the ACP, which has actually risen up and grown very, very quickly. And in fact, they're having a meeting in, I think, New Orleans in about a month, that have become a very serious and credible competitor to the AMA. The AMA is powerful because they have a very strong lobby in Washington, D.C., but the American College of Physicians and other sort of more, I would say, classically liberal professional societies have risen up to sort of fill the vacuums that should not have occurred, right, among the professional societies that frankly abdicated responsibility. So, in a free market, there are adjustments that the system makes spontaneously. We wish that the system didn't have to adjust in this way, that societies like the AMA would have represented their members much more forcefully. But unfortunately, they didn't. They got caught up. Any other remarks or questions? Yes?
Thank you very much for the presentation. Very informative. And I wanted to ask, what would be your opinion as to moving forward, we make sure that this doesn't happen again? Because you mentioned in last afternoon's research presentation about the Spanish flu, about a lot of these, mandates were tried before. And so we learned our lesson from the Spanish flu, or I guess a lot of us weren't alive at that time, or we didn't look back at read from history. So what do you think we're able to do moving forward so that this wouldn't happen again, where the incentive isn't there? Because yes, these positions are, there's good intention and we respect them, and all that, but COVID-19 opened, the response, the pandemic response, opened, many people's eyes as to just how there's lack of trustworthiness when it comes to the media, social media, and with all the information going around. And so, do you think that there's a way for us to separate the incentives from when it comes to critical societal services, so like medicine, for example, or education? Because I don't know if you've been noticing, but right now, a manifestation of what happened in COVID is happening right now with universities, but it's in the political, it's politically right now, but I just said, it's happening again, or it's going to happen, and so just how do you recommend your opinion?
So let me repeat the question and maybe rephrase it for brevity. So the question is, how do we prevent something like that from happening again, where we found that members of the professional class, which are supposed to protect the interests of their patients, in many ways sort of abdicated their responsibility, right? And we see that in many different spheres, not just in a public health crisis. And so actually, I would like to throw that open to you guys. I mean, you heard what I think should happen. I think certainly strengthen the institutions that protect individual freedoms, and especially the freedom of expression. There's a reason why it's the First Amendment, right, is foundational. I mean, if you don't have a strong appreciation for that, till now, look at what happened between 2020 and 2025, 2023. When we finally sort of, came out of this crazy period. I think that if the First Amendment, the freedom of expression, the freedom of speech, had been enforced, first of all, by the authorities that are supposed to enforce it, the courts, for example, right? If that had been enforced, I think we would have a fairly different outcome. For example, in the early days of the pandemic, I think it would have been understandable and probably reasonable, to close schools. Why? Because we don't know. We don't know how severe it was. We know about coronaviruses. We know that a version of the coronavirus, SARS, had a very high mortality rate, relative to other coronaviruses like the flu. Okay? So we didn't know at that time. So with not much with not much strong evidence in the first, maybe month or so of the pandemic, I think it was appropriate to say, let's batten down the hatches. But then the evidence started coming out very quickly, right? The graph I showed you about the relative risk by age group. So that came out. And at that point, it would have made a lot of sense for the doctors, setting aside the authorities, because once you make a decision, it's very difficult to reverse. I think it's very difficult to adapt. But the doctors could have said, you know what, we know enough now that we probably should open the schools, and they should have advocated for school openings. And which, by the way, we saw that, so it was not unique to this country, it was around the world, right? We saw that Sweden, for example, reopened the schools. In Singapore, they reopened the schools after, I think, 6 weeks, when it was very clear. So the learning losses were minimal, right? Schools were running at full speed, after basically an initial closure, and they realized kids are really not, really not at risk. So, let's just make sure that we minimize the consequences of learning losses. So I think the key is to, put the primacy of evidence above either political ideology or what we think we know, right? So, for example, the thing with masks, right? So there was this broad, then it came out very quickly that these cloth masks were completely ineffective. And there was a very nice study. This was a randomized control field experiment, clustered randomized control field experiment in Bangladesh. And I don't remember the reference now, but I can find it and I'll send it to you if you're interested. That randomized experiment studied 250,000 people. It was randomized by villagers, and they were given various types of masks. The long and short of it is that the only masks that might have shown some impact, fairly minimal impact, were these N95 masks. But ultimately, after the experiment ended, the infection rates were the same. And the reason was that these were very difficult to wear. And then you couldn't wear them 24/7. You have to eat, for example, right? And so that should have, that experiment, which ultimately became published, should have already given very strong clues to the public health authorities that, especially if you want a mask, it's up to you. I think the mask manufacturers, like 3M, are very happy about that. But, to force toddlers, 3- and 4-year-olds and 6-year-olds in the kindergarten to wear masks, when we know that early childhood development depends on physical interaction and the ability to interact first with facial expressions, all that was cut off. So we don't even know what the impact, actually none of the studies on learning losses looked at toddlers. Because how do you survey them, right? We don't know that. And they're not formally in school. But we expect that the impact might be quite serious in terms of social development. So I think the key is to lead with evidence, right? And that if there's anything that the NIH or the CDC or any of the federal agencies could have done differently, was to make sure that they funded these early experiments, rapid experiments, quickly to gather evidence. That was the key. Gather as much evidence as you can so that it will inform whatever your policy is, that your policies are informed, they're grounded, but most importantly, that you can make an argument to the people, right? You could say, look, the reason we do this is because here's the evidence. Here are the studies, here are the randomized experiments, here are the trials. And there was an ability to do that. There was an ability to do that. Singapore, for example, had something like 25 different trials of all kinds of stuff. Hydroxychloroquine, all these early interventions that people were basically hypothesizing that could work or not work. Singapore ran, all of these in randomized control experiments, trying to find. Hopkins had some randomized control experiments on various interventions, but they did it on their own, right? It wasn't, with the support or with the blessing of the government. The government, unfortunately, for whatever reason, just didn't seem terribly interested in the evidence once a narrative had been established. Someone had a hand up here. Anybody else? Yes.
How receptive is the public health community to this message that we need to, do you think that the public health community has learned a lesson that we need to have an honest debate?
So the question is, how receptive is the public health community, to a message like that? So you notice that the panel that I had was with doctors, right? Jay Bhattacharya is an MD, so he is trained as a doctor, but he basically works mostly as a public health researcher. He's an epidemiologist as well. But nonetheless, I think this is an interesting question, and the short answer is, I don't know. We are hoping to get this published soon, hopefully in a couple of weeks, and then we'll see what the reaction is. I think there are a couple of things that would be interesting to consider. Number one, if you think about what public health, what is the mandate of why does public health exist? Public health exists in part to understand and to study health issues at the population level. Right? So, they're much less interested necessarily in the individual patient care, doctor to patient, although there are many doctors that work in public health. They're more interested in understanding interventions and epidemiology and incidences and prevalences of diseases in the population, how it spreads, what do we do to control the spread, and etc. So, I think that that's sort of the perspective. So now part of being able to properly implement a public health intervention is messaging. One of the lessons that was learned very early on is that you must have consistent and clear and simple messaging because you are trying to communicate with a broad audience, right? And so good examples of that is, for example, smoking. One of the reasons why smoking rates have dropped, and as a result of that, lung cancer rates have dropped significantly, is because of these public health interventions that depended on clear, simple, easy to understand, easy to convey messaging. So that's the lesson, and there have been a lot of successes on that. MMR vaccine, vaccination. So I think that, it will be an interesting discussion to have. What happens when you don't have very strong evidence, and yet you have to respond at a population level, right? So, and I think somewhere in there, is a balance, meaning, yes, you must have good, clear messaging, which is what they do and they do well. You must have good implementation protocols to ensure that everybody in the population, at least as many people as you can get, comply, but that there's a missing piece, at least in this example, which is where is the evidence for the messaging? So get the evidence first, and then I think the public health mechanism becomes very, very powerful. And as we have seen, it has been very successful for everything from polio to measles to smoking. Maybe the thing that didn't quite work very well until the advent of new therapies was obesity. Right, so as a health issue, or maybe they didn't pay very much attention to it. But there is a very good track record of public health interventions, and I think in this particular instance, for whatever reason, maybe because of the strong hand of the government, the public health intelligentsia, I would say, sort of took a back seat. Yeah.
Let me add one more. You asked the question, what do we think? I made a presentation yesterday, people my age are much less likely to follow the rules. I'm paraphrasing.
Yeah.
And I think that's because we've had many years of opportunities to create a healthy dose of skepticism what the government and the media tell us.
Yep.
I think one of the takeaways here is that more people should be more skeptical at times to speak up and act upon their skepticism. And we've seen that with the population's trust in institutions has plummeted. I think that's strictly as a result. But we as people can't just depend upon physicians to speak up. We need to speak up more too.
So the comment here is that I think, another I guess, thing that we can emphasize is that people have the right and the responsibility to speak up, right? To be skeptical, especially, I would say that, except for very few circumstances, if a government official, Reagan had that funny saying, we're from the government, trust us, right? So if a government official believes that they're dead right about a certain course of action, then it sort of makes sense to be a little bit skeptical and to question the basis of the policy, the evidence supporting it. And these are all things that we can do. So, and I think as individuals in a free society, it is our right, and I would say it is our responsibility, to speak up. And by the way, you can find strength in numbers. So as I said, there were 1 million signatures on the Great Barrington Declaration. So it isn't as though this was something sort of fringe or off to the side. It was sold as that, right, by the authorities that didn't like the message because it complicated their efforts to deal with the pandemic. It certainly did, because now you're asking people to look at the evidence and make a decision for themselves. But there were 1 million signatures. Many of them were well-known researchers and professors and clinicians and doctors and nurses, etc. So, I believe that in every one of these public debates, there's usually more than a single voice. The key is finding others that are willing to have that conversation with you and to do it as a community. And I just want to emphasize as well that, in coming up with this, I would call it a position, the doctors on the panel were very clear that doctors are not public health policy experts, right? They're not policy experts. Some of them are trained. Jay is trained as a health policy expert, but very few doctors. So what do they have to go on? What they have to go on is their professional responsibility to their patients, their understanding of the evidence. All doctors are trained to read research papers because that's how you develop your body of knowledge to treat your patients. And so that's their responsibility. Their responsibility is not necessarily to be a public health official, right? It's to be in the conversation. And the responsibility of the public health official is to make sure that there's inclusiveness. That's that word, but really there has to be inclusiveness from different points of view, because only then can you develop something that has the wisdom, of different experts, right, that speak into this. In a public health crisis like that, it's not unidimensional. The other problem was that this was seen as, and I think acted upon as, primarily a health issue. And of course, it's a virus, but it really turned out to be more than just a health issue or a public health issue, right? There was an economic issue attached to it, obviously individual liberties. There was an educational issue that was attached to it because of the widespread, mandates and sort of the multidimensional nature of the mandates. So once you get to the point where really a particular phenomenon is more than just a single issue, then that implies that you have to get experts that know about all these other dimensions of the phenomenon in the conversation. And yes, it might slow down the response, but in a crisis where the evidence is still emerging, where people don't actually know what's going to happen, you can have an immediate response, but you must always be willing to reverse course based on the evidence. And I think the public, I have, I think, a great trust in sort of public wisdom, what my dad calls cow sense, right? He uses the word cow sense. Now, what is cow sense? Animals have a certain common sense, right? And I believe that the public, I think, is generally grounded in good common sense. And if you tell the public, look, we thought that was going to be like that, but we are changing our position because the evidence suggests that this is a better way to go. I think that's how you develop trust. I think that's how you get the public to engage and to say, okay, we see where you're coming from and you're telling us this is the evidence. And by the way, we can see the evidence for ourselves because especially if there's studies that are being done, we can still choose to agree or disagree with it, but we understand why. And if you reverse course, it's okay. And I think that's a great fear, perhaps among public officials, that if they reverse course, right, or they change, they're seen as flip-flopping. I think that's the worst term that you can use in the political lexicon, which is flip-flopping. Flip-flop, it might be flip-flopping, but it could also be you've developed new evidence and you're going to go in a better direction. So my view is, both for officials that have to develop policy, don't be afraid to flip-flop. Take it as a badge of honor that you're flip-flopping because the evidence suggests you should, as opposed to doubling down and making things worse, which is, I don't know, it's terrible. All right, we've got 5 more minutes. If there, is there anybody else that hasn't asked a question? There you go, sorry.
First of all, thank you for doing this research and for speaking up. Even though we're several years past the peak of the pandemic, have you personally experienced any pressure to modify your message? Perhaps personal warnings from colleague friends of professional consequences?
So the question is, have I experienced professional consequences of speaking up? Now, we are several years from the pandemic, so it's a little bit easier to speak up now. Okay, fair enough. Some of my colleagues that were on the panel were in fact censured. Jay was censured by the Stanford Faculty Senate for speaking up. He persisted. Actually, I tried to recruit him to Hopkins saying, hey, we've got a place here for you. But you can't leave Palo Alto for Baltimore, right? I hope this is not recorded. How do you leave Palo Alto for Baltimore? Anyway, I know of personal people that had experienced professional consequences for speaking up. I myself, I would say that I have experienced it, but in sort of an indirect way. So the research that started, so the survey that we did was in June of 2020. So very early on, we actually did a national survey. This was the research I presented yesterday. I couldn't get it published. I sent it to 6 journals and it was just rejected by the editors with no reason. And some of them basically said, this is not within the mission of the journal, which was not quite true because you obviously look at the journal mission before you submit something. So it's eventually gotten published, but only 3 years, after the original study, when things sort of died down, it was more acceptable to publish contrary points of view. So that in fact did happen. But what do? You persist. You just keep going. So we kept trying to get it out there, and then eventually, yes, it did get published. I will say, for the record, that actually since then there has been a lot of papers that are coming out. That are now sort of, it's almost like they were all bottled up, and now that it's sort of acceptable, right, for journal editors to look brave, they're all coming out now, whether it was masking, whether it was learning losses, the studies that we looked at mental health issues and addiction behaviors. So we saw that, substance abuse went up, alcohol abuse went up. This was during the time of the lockdowns. Sort of a direct consequence of those measures. So the studies are coming out now. Yeah, but it's 3 years. We hope that these studies will form the basis, the knowledge base for future responses. And there was an earlier question: what do you do when it happens again? And it's 100 years from now, and we weren't alive in 1819, or at least I think most of us were not alive in 1819. Well, I think you develop a body of knowledge and you make sure that those who are responsible for archiving that knowledge know that it's there, and that future generations of scientists and public health officials and doctors who have to interrogate the knowledge base in order to provide care do so, right, with honesty. I think strengthening education to reinforce the values of individual expression, free expression, inquiry, critical thinking. I think, it really begins there. And if you do that, then I think you can hopefully be assured that future generations will at least mount an adequate defense. Because I will tell you that the incentives for these kinds of mandates, that will not go away. And it isn't from an evil intention, right? The officials were trying to protect the public, so fair enough. But unfortunately, as we can see, the consequences were unintended and quite severe. Thank you.
That's a good place to leave off. We're out of time, but let's give one more round of applause.
Thank you.